Hey, good afternoon. My name is Michael Farrell. I'm the president of APSAD, and I'd like to welcome you here this afternoon, and I'd like to pay my respects to the traditional owners of the land, past, present, and future, and also to take note that we're meeting across many lands. What we have here today is we have a thing that we haven't done before. Because we're not having a meeting in person, we're having our APSAD Awards ceremony online, a virtual award ceremony, and we're also going to have a talk from our early career researcher and also a talk from one of our other senior researchers. The order of the thing will be we'll go through the awards and we'll have a brief word from the awardees. Then we will actually get to the two presentations, and this will take from now until about 2:30. The six awards we have today are the First People's Award, Senior Scientist Award, Mid-Career Award, Mentor Award, Clinician Award, and Early Career Award. And these are all they're awards for the membership organization. Really, they're by peers in recognition for work done, and they're very important to see that people get appropriately awarded. I would like you to think in terms of this year and the coming year, if you can think of people who you think are meritorious. We welcome submissions for these and we want very active membership involvement in the nomination for these. Each award recipient receives a plaque and a certificate and money to subsidize the cost of attending the 2021 APSAD conference and one full year membership of APSAD. So I'll carry on, and to begin with, I'll announce the First People's Award goes to Robert Assan, who's in Queensland. Rob has made a major contribution to upskilling health and other professionals, teaching them to work with Aboriginal and Torres Strait Island people around alcohol and drugs. For much of his career, he's been involved in supporting and mentoring staff into design and rollout of state and national training programs. He's a talented teacher and communicator, and he has a unique ability to keep a room spellbound. Participants come away with changed attitudes and thinking. Their insight, skills, and confidence increase, not just their knowledge. His teaching approaches have been adopted into graduate and postgraduate courses at the University of Sydney. His training and training techniques have also been part of a large national trial funded by the NHMRC, and he recently was the first author of the original and Torres Strait Islanders section of National Alcohol Treatment Guidelines. So over to you, Robert.
Hi, before I begin, I'd like to acknowledge the traditional custodians on the land on which I stand today, the Wulkawurrubba and Bindal people of the Townsville area. My name is Rob Assan. I'm a descendant of the Torres Strait Island and Cape York people. I was born in Darwin, Northern Territory, and lived most of my life there. I've been working in the ARD field for about 25 odd years. Most of my work has been around training of both Indigenous and non-Indigenous people on ways of working.
What's happened?
Sorry, I accidentally cut it off. I'll put it on.
Before I begin, I'd like to acknowledge the traditional custodians on the land on which I stand today, the Wulkawurrubba and Bindal people of the Townsville area. My name is Rob Assan. I'm a descendant of the Torres Strait Island and Cape York people. I was born in Darwin, Northern Territory, and lived most of my life there. I've been working in the ARD field for about 25 odd years. Most of my work has been around training of both Indigenous and non-Indigenous people on ways of working with our people, also working one-on-one. Currently I'm in Townsville and I work for the Cleveland Youth Detention Centre, working with the youth to address their alcohol and mental health issues. I'd like to thank a couple of people for this nomination, for nominating me for this award, Professor Kate Conograve and Associate Professor Kylie Lee. I'd also like to mention and thank my mentor who's no longer with us, Coralie Ober, for her support and guidance throughout the years. I think without Coralie, I probably wouldn't be still doing this job, but with her support, guidance and faith, I've been able to keep going. And I'd also like to thank APSAD for this award. So thank you very much.
Thank you very much, Robert. And congratulations. So now I want to move on to the next one, the senior scientist, and that goes to Clinical Associate Professor Robert Ailey, who is known to many of us, who's made a major national and international contribution to the field over 4 decades. He's been the director of DASA, director of the WHO Collaborating Centre for Research and Treatment of Drugs and Alcohol in the University of Adelaide, and he's been a clinical associate professor in drugs and alcohol studies at the University of Adelaide. Robert's international work and work with WHO and generosity in supporting people and working across policy in the last few decades is second to none. And I'd like to ask Robert to say a few words.
I'd like to thank APSAD for honouring me with this award. Looking at the previous recipients, I feel both humble and proud. Thank you very much. I do very much appreciate it.
That was short and sweet, Robert. Thank you very much. So the next award is the Mid-Career Award, and that goes to Associate Professor Suzanne Nielsen, who, with her clinical background and passion for clinical care, she's used research to make a real difference. Her CV outlines an exceptional career. She's done a lot of work on buprenorphine, naloxone, and her work around the interface between pharmacy and drug dependence treatment has been critical. And she's, since moving to Melbourne and working with Monash, she's developed a large program of work. So I'd like to invite Susie to say a few words.
So it's a huge and humbling honour to be awarded the APSAD Mid-Career Researcher Award. I find the mid-career research stage is a bit of a strange time, like an awkward adolescent period between being a shiny new ECR and the point at which I hope I'll finally feel like I know what I'm doing. So I have 2 minutes to say thank yous, which is tough because at this stage of the career, I am both incredibly indebted to my mentors, both past and present, but also incredibly grateful to all the emerging researchers that I work with who actually make me look productive and are really the future of this field. So I tried to work out how to name enough people in 2 minutes to really give credit where credit's due, and it was really tough. I would say it's impossible. On the slide now, you can see all the people that I've published with since doing my PhD, and it's really an all-star cast, and I have learned something from every one of them. I also tried narrowing it down to the number of people in different institutions that I've worked with, and you can see again, it doesn't make it any simpler. So I'm clearly going to do a disservice by trying to name everybody that I've worked with, but I do owe a huge debt to all of these people. But in particular, I wanted to acknowledge my supervisors and mentors in chronological order. So Dave Taylor, Nicole Lee, Adrian Dunlop, Paul Dietz, Nicole Nzeris, Walter Ling, Louisa Degenhardt, and Alison Ritter. And in particular, Alison and Paul have been enormous supports as I've transitioned to a mid-career phase and relocated back to my hometown in Melbourne. I'm also enormously grateful to the current team that I work with at Monash, and I could not want for a more supportive team, including my boss, Dan Lubman, who gives me incredible trust and autonomy to do this amazing work. Finally, I just wanted to say thank you to APSAD for everything that you do for the field, and also to thank my family, in particular, Johnny and Henry, who put up with me through all of this. So thank you.
Thank you, Susie, and congratulations again, well deserved. And then the Mentor Award, which goes to Paul Dietz, who needs no introduction, but has had an extensive career and made an immeasurable contribution to the alcohol and drug field, and particularly through his work on the journal and Trojan work in the journal. But he's also, in this capacity as mentor, he has been critical in providing support for many different researchers across the field to see that they become engaged and inspired to do further research. So over to Paul for a few words.
Hi everybody. I'd like to begin by acknowledging that today I'm in Wurundjeri country that's never been ceded, and acknowledge elders past, present and emerging. It really is a great honour to be receiving the 2020 APSAD Mentor Award. It's, you know, the alcohol and other drug sector has so many outstanding examples of fantastic mentors. It's really humbling to be receiving it. I'd like to thank my colleagues for nominating me and APSAD for awarding it to me. Here it is here. Beautiful little glass plaque. Look, mentorship's really important. I've been lucky enough to have had many fantastic mentors, and I'd like to pay special tribute to Alison Ritter and Lisa Marr and the Margarets, Hallard and Hamilton, but a special mention for Gabrielle Bammer, who really was the first person to properly challenge me in my career direction. But all of these brilliant women, we're really lucky in the sector to have them as outstanding leaders and role models. I personally find mentorship and supervising students the most satisfying part of my work, the incredible achievements that they've all had. And just watching their careers evolve is really inspiring. It's kind of what keeps you going. But even as a mentor, not everything goes to plan, and you know, sometimes you make mistakes, and it's important to acknowledge them and learn from them and learn how to move on. It's been a really tough year for everybody, I'm sure everyone's aware. We've had 3 terrible diseases. We've had COVID, we've had Zoom, we've had isobeers. But it's been amazing how well everyone in the sector has been able to adjust and keep producing this fantastic research, clinical practice and responsive policy. I guess nowhere has it been harder in Australia than in Melbourne. And it's been really inspiring to see how the sector has been able to work to really respond well to what people with alcohol and other drug issues need. I guess the thing that has inspired me the most, though, is how well my team has adjusted to this really challenging environment. Yeah, they've been amazing. But I guess in the end, it's a shame we can't be up there in Brisbane celebrating this conference together. But hopefully in 2021, we'll all be able to come together and we'll see each other face to face again. Look forward to that then. Okay, bye everyone.
Thanks, Paul. Thank you very much, Paul.
See it here. I've got my little plaque. Mentorship is so important. I've been lucky to properly challenge me in my career decision making and luminaries in it to be counted amongst. Had 2 terrible diseases, COVID and Zoom. Look, the alcohol and other drug sector has. In the end, it's a bummer that I'm having to give this over Zoom. Bye, 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 bye.
I'm not sure what happened there, but anyway. So thanks very much, Paul. Now the next award is the Clinician Award, and that goes to Dr. Tony Gill, who's an addiction medicine specialist and who's the Chief Addiction Medicine Specialist in New South Wales Health, and has started in Victoria and has been in Queensland and New South Wales, and has provided a really steady hand in the clinical field as a wise and measured person. So it is with great pleasure I ask Tony to say a few words.
Thank you very much, Michael, and thank you, APSAD, for this award. I must say it came as something of a surprise and has created a slight imposter syndrome in me, but thank you very much, and I'm very honoured to receive this award. I'm particularly honoured to receive this award from APSAD because as a clinician in the field for over 30 years, I've been been able to, receive a lot of support and help from APSAD over that time, as all clinicians have, in terms of its provision of education and training and conferences and the journal, resources, and just the way it just connects clinicians up generally. So it's very pleasing and to receive this award from APSAD, who have been a great support to clinicians in New South Wales. When I reflect on this award and my path as a clinician, it's really been enabled and supported by the many extremely skilled and talented colleagues that I've had the good fortune to work with, and that I still do work with. I've been fortunate to work in Victoria and Queensland and mostly in New South Wales and in a range of places in New South Wales, and I've benefited enormously from the direct and indirect learnings and support from colleagues. And this has enabled, I think, me, and it enables all clinicians to develop in this field. So I'm very grateful to them. And these colleagues have been medical practitioners, social workers, psychologists, nurses and counsellors and others. And so I see this award in effect as an acknowledgement, an acknowledgement also of the terrific people that I've had the opportunity to work with and to learn from. The other thing I'd just say briefly is that it's a great privilege and a rare privilege I think we have as drug and alcohol clinicians to have people share their most private and confidential aspects of their lives and allow us to accompany them and work with them and help them achieve what they want in terms of their drug and alcohol problems. And I just would like to acknowledge that this is a very serious responsibility, but incredibly rewarding honour to work with people like this, and it makes clinical work, I think, incredibly satisfying. And I'd encourage other people to look to this sort of work as well, because it's a great field to work in. So thank you very much, Michael. It's been an absolute pleasure to work in this field for the period that I have, and I will probably keep doing that for some time yet, but it's a great honour to receive this award from APSAD. Thanks very much.
Congratulations, Tony, and we certainly hope you do keep working for a good while. So now the Early Career Award goes to Dr. Cheneal Puljevic, who has had a very dynamic rise and trajectory in the last while and has done important work around smoking in the prison system. And I will let her speak for herself. She's going to give us a short presentation, which I look forward to.
Great.
You, Cheneal.
Michael. Just doing screen share. All right, just to play Zoom bingo, can everyone see my screen?
Yep.
Excellent. All right. Hi, everybody. My name is Cheneal Puljevic. I'm very honored to present today's Early Career Award webinar. I'm a research fellow at the Centre for Health Services Research and a lecturer at the School of Public Health at the University of Queensland. And today I'm going to be presenting on missed opportunities to reduce tobacco smoking among people who experience incarceration or homelessness. So before I begin, I'd like to take 30 seconds to acknowledge a few people whose support and mentorship are the reason I won this award. It is a real honor to win and have this opportunity, and especially knowing the caliber of the other early career researchers in the field, and I'm very grateful. And clearly my Photoshop skills are not one of the reasons why I won the award. So first, my two current supervisors, Jason Ferris and Carl Gartner at UQ, who have gone above and beyond in identifying every opportunity to help advance my career. In particular, Jason, who's nominated me for this award and is everything that an ECR could want in an academic supervisor and mentor. I will be presenting some research from my PhD today, so I'd like to acknowledge my amazing PhD supervisors who taught me so much, Professor Stuart Kinner, Dr. Dominique de Andrade, and Professor Ross Coomber. And finally, a huge thank you to APSAD for the award and for all that you do in supporting early career researchers in the alcohol and other drug field. Before I begin, I wanted to quickly mention that I've been lucky enough to work on a very wide variety of alcohol and other drug related research topics. since I completed my PhD 2 years ago. So some of these topics are listed here, and I'm always open to collaboration opportunities. But today I'm here to talk to you about my primary area of interest, which is listed at the bottom. So that's tobacco smoking cessation among people who have experienced incarceration or homelessness. This is a very brief overview of today's presentation. So first I'm going to discuss tobacco smoking among people who experience incarceration, which was the focus of my PhD completed 2 years ago, and I'll be presenting findings from a few studies on that topic. Second, I'll discuss tobacco smoking among people who experience homelessness, which has been the focus of a recent UQ ECR grant that I was awarded last year, where I conducted a cross-sectional survey of smokers living in a homeless hostel in Brisbane. I want to focus on what these two populations have in common, why smoking cessation is particularly important for these individuals, and I'll briefly cover ways in which we could promote smoking cessation among smokers from these populations. As I only have 15 minutes, unfortunately, I'm going to have to skip over some of the more interesting details and only focus on the main points, but I'm always open to chat later. So let's begin. Approximately 74% of people entering Australian prisons are smokers, which is a rate of 6 times the general population's rate of 12%. And I hardly need to tell this audience that tobacco smoking is the world's leading cause of preventable death. Unfortunately, there is extensive evidence showing that these individuals experience elevated rates of chronic and complex health problems compared to the general population, with the time period following release from prison characterized by particularly poor health outcomes, such as high rates of preventable hospitalization and mortality. And this, of course, includes high rates of smoking-related illnesses such as cancer and cardiovascular diseases. Partly in response to this, prisons around the world have implemented smoke-free policies or smoking bans, meaning that everyone who enters prison in these countries is immediately forced to quit smoking. In Australia, these policies apply in all states and territories except Western Australia. Studies conducted in the USA estimate that around 60% of people who were smokers upon entry to prison resume smoking on the day they get out, and 97% have resumed within 6 months. So that's almost universal relapse to smoking post-release. These figures suggest that these prison-based smoke-free policies result in short-term smoking cessation only and not long-term behavior change. And before our research, there were no studies on this topic outside of the US. So for my PhD, I conducted a mixed methods project aiming to quantify and understand post-release relapse to smoking, among other things. And today I only have time to tell you about the quantitative study. So this involved a verbally administered survey conducted at 12 probation and parole offices across Southeast Queensland. To take part, participants had to have been daily smokers upon entry to prison and had to have been released from prison within the past 2 months to ensure their memory of their post-release smoking behaviors was relatively clear. All of the participants received a $20 supermarket voucher as a reciprocity payment, and the survey measured their cigarettes per day before and after prison, their alcohol and other drug use before, during, and after prison, and their views on smoke-free policies. So we recruited 114 participants. The majority were male, mean age of 34, and 23% identified as Aboriginal or Torres Strait Islander. And participants were incarcerated for a median of 14 weeks. So that means for most people, they had passed the typical duration of nicotine withdrawal. Around half supported the prison smoke-free policy, and 66%, so that's 2/3, actually intended to remain abstinent from smoking following release. So it shows that they really did want to try and stay quit after they got out. So this graph shows their rate of relapse to smoking following release from prison. So by the day after release, only 28% were still abstinent from smoking. A week later, only 11%, and 2 months later, only 6% were abstinent. So that's 94% of my participants had resumed smoking within 2 months of getting out of prison. And I've included the citation for this paper at the bottom of the slide in case you want to read more. These results point to a clear need for strategies to promote continued smoking cessation among people released from smoke-free prisons to help them capitalize on and maintain their hard-won abstinence. So before I continue, I want to tell you a quick side story, because we all know that telling more than one story at once is far more fun. So here's a side story about an unexpected study that I ended up doing as part of my PhD. I found out during the quantitative survey that many participants had been making their own cigarettes in prison, nicknamed Teabacco. So they would buy nicotine lozenges in prison, crush these, mix them with tea leaves, and roll that up in Bible paper. During the quantitative study, we found that 57% of participants had smoked it at least once, and 37% were smoking at least twice a week. So it's obviously not a representative sample, but this suggests that it was a relatively common practice, at least in Queensland prisons. Participants also reported smoking a variety of other substances when nicotine lozenges weren't available, including plain tea leaves, banana peels, grass, and one guy who smoked cane toad saliva. We also got forensic scientists to test a sample of the Teabacco to try and get a sense of how harmful it was. So this picture is of one of the participants making samples for me. That was a really fun day. And we found that Teabacco contained trace elements of things like copper, aluminium, and lead, but in much smaller amounts than traditional combustible cigarettes, suggesting that this form of Teabacco may be less harmful to smoke than combustible cigarettes. And the references for these slides are at the bottom. Sorry, for these studies are at the bottom of the slide. So now to move on to the next study, which was the focus of the small EUQ ECR grant that I won last year. As with people who experience incarceration, studies internationally report very high rates of tobacco use among people who experience homelessness. A recent systematic review of 53 international studies found tobacco prevalence rates of between 57 and 82% among this population. As with people who have been in prison, high rates of tobacco use contribute to their overall poor health, and many wish to quit smoking but struggle to do so, possibly due to addictive behavior cycles exacerbated by their unique living and financial constraints. There is limited research in this area. So for example, I'm unaware of any published research on preferred cessation support strategies among Australians experiencing homelessness, which is obviously crucial information if we want to implement effective programs promoting cessation. So to explore this topic further, we conducted verbally administered surveys with current daily smokers from a men's temporary accommodation hostel in South Brisbane. Participants received a $15 supermarket voucher as a reciprocity payment, and survey questions covered socio-demographic characteristics, smoking and quit history, future quitting intention, and their preferences. And I'll be presenting the results from some descriptive statistical analyses today. So there were 68 male participants, most aged between 30 and 40, and 15% identified as Aboriginal and or Torres Strait Islander. 52% had spent time in prison, so the sample is somewhat comparable to my PhD study sample. And overall, they were very heavy smokers, with most smoking 20 or more cigarettes per day. And this is the part that I find most interesting. As you would expect from a sample of people living in temporary accommodation, a large percentage had a very low income. So 92% were earning below minimum wage, which is $740 a week, but they were spending a median of $80, and a few people were spending $250 a week on smoking. Approximately 80% though were interested in using a smoking cessation aid, such as nicotine replacement therapy. And in terms of what they perceived as the most effective, there was the highest level of interest in nicotine patches and e-cigarettes. So as we can see from this table, these findings suggest that smokers who experience homelessness are more interested in nicotine replacement therapy or prescription medicines than counseling, even though we know that evidence suggests that it's a combination of pharmacotherapy and counseling that's most effective in promoting smoking cessation. So now to bring everything together and highlight the missed opportunities to promote smoking cessation among these populations. So as I've presented, my PhD findings show that Australian prison-based smoke-free policies are not resulting in long-term smoking cessation in the majority of cases, even though 2/3 of the participants in my study wanted to remain quit after release, and the majority had been in prison beyond the typical duration of nicotine withdrawal. As far as I'm aware, the only form of smoking cessation support available in prison, at least in Queensland, is nicotine lozenges, and these have to be purchased, and they're not particularly cheap. And here's the crux of it, is that I'm unaware of any strategies internationally in place to reduce relapse to smoking upon release from prison. So this shows a very clear missed public health opportunity to reduce smoking-related harms among a marginalized and vulnerable and unhealthy population. And then in terms of the homeless population, we found that these smokers were heavy tobacco users, with most smoking 20 or more cigarettes per day, which is of course likely to impact negatively on their already poor health outcomes. And they were spending a high proportion of their limited income on tobacco, thus likely perpetuating their financial disadvantage. There was a high level of interest in cessation aids, about 80% were interested in using them, but again, we are unaware of any organized and targeted efforts to promote smoking cessation among people who experience homelessness. So yet again, this is another missed public health opportunity to reduce tobacco-related harms among a marginalized and unhealthy population. So I feel like everything I've told you today is fairly obvious, and there's nothing particularly groundbreaking in what I've said. And yet there appears to be barely any formal efforts to promote targeted strategies promoting cessation support. I do know that efforts are, of course, always limited by available funding, but in terms of what works, what kind of things could we do to promote and support smoking cessation among these populations? Well, there's a fair amount of evidence internationally supporting behavioral counseling and particular motivational interviewing for smoking cessation. So the WISE study, which stands for Working Inside for Smoking Elimination, is an American study which showed that 6 brief sessions of motivational interviewing delivered just before release from prison resulted in significantly higher rates of post-release abstinence compared to usual care. So that's something to think about. We also know that there's a high level of evidence for the effectiveness of pharmacotherapy or nicotine replacement therapy. And I've found that not a lot of people, not a lot of smokers seem to realize that they can access these at a significantly reduced cost through the pharmaceutical benefit scheme if they ask their doctor for a script. And then finally, I know that this is controversial in some circles, but there is emerging evidence from the UK showing that customized e-cigarettes are effective at promoting long-term cessation among people in prison. And another findings from another trial have just come out showing that they can be very effective in promoting smoking cessation among people who experience homelessness. And just out of interest, here's a picture of a customized e-cigarette that's sold in American prisons. So it's apparently tamper-proof and can't be turned into a weapon or used for any other purposes. So in conclusion, most of what I've presented today can be described as problem-focused. So I'm describing the problem of high rates of tobacco use among populations who can least afford it in terms of health and financial outcomes. So as with many bodies of research, there's a clear need instead for solutions-focused research. So how can we solve this problem? So I hope that in the next few years, I'll be able to find funding to enable us to investigate some of these solutions. So something like an intensive combined pharmacotherapy and behavioral counseling program would be ideal, but I'm also pondering a program that promotes people's most personally relevant reasons for quitting or considering quitting. So rather than, say, most strategies which focus on the health benefits of quitting, perhaps instead focusing more on other more salient benefits of quitting smoking, like the immediate cost savings or improved access to smoke-free housing or something like that. All right, that's it from me. Please contact me if you have any ideas or any questions. And these are the references for some of the studies I've discussed today. Thank you.
Thank you so much, Cheneal. That's a fantastic presentation, and congratulations again on your Early Career Award. And we look forward to seeing you in Brisbane next year, if not.
Look forward to that. Thank you.
Okay, thank you very much, Cheneal. Very well done. So it's now over to Wayne Hall, who needs no introduction, but is going to give us a brief overview of his lifelong experience of research. I think he calls himself a recovering researcher, sort of. So over to you, Wayne.
Thanks, Michael. Just share the screen here.
Here's the screen, yeah.
Can that be seen?
Yeah, if you go on to slide view.
Okay. Okay. All right, well, thanks very much for the invitation to give this talk, which I found a fairly challenging one to prepare. I think I need to begin with some caveats that drawing lessons from history is something that historians disdain, and drawing lessons from a single life is even more of a challenge. Making causal inferences from an N of one study, in effect, when we know that human memory is pretty fallible and that we're inclined to retrospectively impose a great deal of rationality and meaning on our lives than occurred in the haphazard way in which it unfolded. And history matters. So I'm talking about a period when drug and alcohol research was in its infancy in Australia. That's certainly no longer the case now. So one has to be careful in drawing inferences from my experience to the current climate. And as I think needs to be repeated, it's hard to underestimate the role of good luck in a career. And it's all too easy to take credit for the work of others. And I'll try to avoid doing that if possible. I've got to start off by giving a bit of an overview of what I did. And I guess the first thing is I sort of stumbled into the drug and alcohol field, as I know a great many people did. Griffith Edwards' collection of Addiction Lives, that was a very common trajectory. I wandered around various fields, starting off in experimental psychology, working in health services research, psychology of chronic pain, research consultancy, teaching medical students. So there was quite a long time before, well, the time I finished my PhD in '77 until I started at NDRI. It was 11 years of varied experiences. The National Drug and Alcohol Research Centre, when I began, had been established in 1987, along with INDRI in Perth, and it was the outcome of a 1985 Special Premiers Conference, which it's worth noting was really enacting a recommendation made back in 1977 by a Senate committee report chaired by Peter Barn. I came as Deputy Director to Nick Heather, who was the Foundation Director of the Centre, and I took up the job in the face of considerable cautionary advice from mentors who were saying this would be a career dead end. I shouldn't take the job. Drug and alcohol wasn't going to go anywhere. It was a very small field and it would be hard to make much of an impact. And when we started at NDUC, we started from scratch. We were expected, there were big expectations of us, and we had to get runs on the board in the form of publications and outputs that people in the field would appreciate. So we had to be opportunistic. We had to take the opportunities as they presented themselves, either in requests for funding, politicians' interests of requests, data being available, an interest from the field, and critically access to patients and people who use drugs whom we could interview about their experiences. And more organised research programs, which are now a central part of NDRI's activities and indeed of all the national centres, really emerged over time from early commission work in discussion with funders and in response to specific funding requests, and later from competitive research grant applications. So I'll give a couple of examples of how this worked at NDRI in the time that I was there. So in the case of heroin use, the centre was largely set up in response to an epidemic of heroin use in the early to mid 1980s. And as people probably know, the daughter of the then Prime Minister, Bob Hawke, had a problem with heroin, which was widely publicly acknowledged, as did in fact several ministers in the federal cabinet. So heroin use was a very hot topic at the time. And so we're under considerable pressure to get up to speed on that. And we started off, Richard Maddock did, in developing treatment guidelines for the treatment of alcohol, tobacco and opiates. And that led into a commission review from the New South Wales Department of Health to do a review of methadone treatment that Jeff Ward led, along with Richard and myself. Shane Dark and Deborah Zadel, who was affiliated with the centre, began to do work on fatal heroin overdose. Initially, that was research investigator initiated in the case of Deborah and Shane, but we're also later commissioned to do work on trends in heroin overdose. And we also began to do quite a lot of work on epidemiology of heroin use and harms. This was when Lisa Ma started her work on ethnographic research on heroin use in southwest Sydney. We did work estimating numbers of heroin users, work for the WHO on the contribution of heroin use to the GBD. And we began to do clinical trials. Richard got up funding for a buprenorphine trial that was pivotal in getting buprenorphine approved as a treatment option for opiate dependence, and later led the NEPOD project. And the Australian Treatment Outcome Study, led by Marie Thiessen and Shane Dark, did a lot of work on long-term outcomes from heroin dependence. And just to indulge myself in talking about one example, this was work that began with a request from the Commonwealth to produce a brief report on what had happened to heroin overdose deaths in Australia between 1964 and 1999, which was around the time the Commonwealth was making a decision about whether it would fund a heroin trial in the ACT. And of course, what we found was a very steep increase in heroin overdose deaths over that period, particularly from the 1980s through to the late 1990s, which is where the data was available. What was more interesting is we could use that data to basically plot the history of heroin as a problem, and what the American experience had been in the much earlier in the 1940s and 50s was that before that period, most overdose deaths occurred in middle-aged women who'd acquired dependence as a result of medical treatment. And after that date in the US, it became a predominantly a male cause of death, and which is what we saw here beginning in 1968, 69, went from primarily female cause of death to almost wholly male cause of death, and then the majority of these deaths occurring amongst males. The other thing we saw was the same change in deaths, average age of death. The deaths before 68 were primarily in women in their early 30s. After that, they began in young men in their 20s, and we saw this steady increase in the age of death, which suggested to us that there was an aging cohort in part driving this sort of phenomena. And one of the things we then did was to look at cohort trends in overdose deaths, showing that effectively heroin overdose death was a phenomenon that really began in the baby boomers. There were deaths in the earlier, older age groups, but it began in the baby boomers, and it increased in more recent birth cohorts. And the age at which these deaths began to occur declined with each birth cohort, and we were able to show from data on large numbers of heroin users that reflected the age at which people began to use heroin. The older birth cohorts started later than the more recent birth cohorts, who tended to start in their mid to late teens. So that's an example, I guess, of a commission piece of work throwing up all sorts of interesting questions and leading to a series of nice papers and interesting innovations in method. The research we did, I was involved in at NDRI on cannabis use, started in very much the same way. It was a commissioned review from the Commonwealth on the health effects of cannabis that we did in 1994. It's led to a Lancet paper in 98 and commissions from WHO and the Commonwealth, and more recently WHO again to update these. Also did work on medical uses of cannabis that led to evidence to the House of Lords and a working party for the New South Wales Premier. And we also then managed to get funding to look at long-term cannabis users and cannabis use disorders. And Jan Copeland, Wendy Swift and others began to develop treatments for cannabis dependence. I ended up wandering into the sort of broad field of cannabis policy and debates around it, and did work with Rosalie Pakula. It began before I left NDRI and continued into my time away. We also began work on psychiatric comorbidity, which began, interestingly, the same way. Request for me to give a lecture on what the epidemiological studies in the US had told us about psychiatric comorbidity. And it occurred to me in the course of doing that it would be interesting to try and get an Australian survey up. And Gavin Andrews and Scott Henderson, who are eminent psychiatric epidemiologists, helped lobby for that. And we found a very receptive voice in Harvey Whiteford, who was the secretary or the chief advisor on mental health to the health department. And we brought about the first national survey of mental health and wellbeing, which was interesting because I remember the first meeting with the Commonwealth Department of Health with the mental health branch, and the secretary of the branch saying that there was no need to include questions on alcohol and drug use disorders in the survey because what did they have to do with mental health? So we had a battle to persuade mental health that we had to include alcohol and drug disorders in a national survey of mental health and wellbeing. And of course, the consequence was discovering their high prevalence and their high rates of comorbidity with other common mental disorders, which subsequently became a major theme in research at NDRI, including the Australian Treatment Outcome Study. So what did I learn from being a centre director? I was centre director from 1994 to 2001, beginning after Nick Heather returned to the UK to take up a chair there. And as I've already indicated, you had to be opportunistic and try to be strategic in those sorts of opportunities that you took. And you needed a good partnership. And in my case, it was Richard Maddock, who had unparalleled skills in project budgeting and management, which were skills that I'm glad he had because I don't have them as well developed as he did. Richard would notoriously do sums in his head about what a project would really cost. I almost always underestimated how much and how long they'd take. He was usually spot on. The other thing was I spent a lot of time repaying the good mentoring I'd had earlier in my career by doing the same for the younger people we attracted to the centre. Paul Dietz has made the point in his speech accepting the Mentor Award for APSAD. This is a particularly rewarding part of running research centres, particularly as you become an older and more senior researcher. The other things that I did, which I think were important, was responding to requests and questions and commissions from government. Academics are sometimes reluctant to do that, insisting on only doing peer-initiated research. I think you have to do both, but I think it's critical to be seen to respond to these sorts of requests. And it also demands that you write for a much wider audience than your peers, because policymakers and the public don't read peer-reviewed articles. That means writing in an accessible and engaging way, and I'll come back to talk more about that later. It also meant being ready to take on contentious topics, such as cannabis policy, methadone treatment, which was very controversial when the centre was first established, the debate around heroin maintenance treatment, injecting rooms, and to display a characteristic which Ingrid Van Beek has described as resolute reasonableness in the face of often hostile criticism from partisans or critics of particular approaches to treatment. That wasn't always comfortable, particularly when you had public figures accusing you of promoting drug use in the media. But it was a baptism of fire, but it was possible. Why did I leave NDRI? Well, 2001, I turned 50. As often happens when people hit that age, you begin to wonder, do I want to spend the rest of my life doing what I'm doing now? What are the opportunities of going back and chasing up some other career option that I could have led that I abandoned in the past? And in my case, it was an opportunity that arose with an advertisement for a job at the University of Queensland to conduct work on ethics and policy implications of bioscience, molecular bioscience research. And this had been a long-standing interest from undergraduate, postgraduate days. I rashly sent an email to the director of the centre saying, I don't have a track record in this field, but I think I could do this, and if you were to offer me the job, this is what I do. And he was courageous enough to take a chance on offering me the job, and I was crazy brave enough to accept. I think the consternation amongst people at NDRI when I announced this decision was puzzlement and astonishment. But I had a lot of good luck in the people I managed to recruit when I moved. people with specialty skills in research librarianship in molecular biology, social science, and environmental health, and later on ethics and philosophy. The challenge, of course, was there was no field that really existed in Australia. There were individuals working in the field. I had no track record. There were a few peers, and there were the standard problems with academic trade unions that you applied for funding through the ARC. It was reviewed by a political scientist or a philosopher or a social psychologist who said, you're not a member of the academic trade union, you don't have a track record, so you shouldn't be doing this work. So a consequence of that was I did succeed, as we'll see in a moment, in doing work, but I had increasingly frequent relapses to drug research. The first of which came within the first year at UQ was a WHO commission to do work on ethical and policy implications of genetic and neuroscience research on addiction. And I also continued to collaborate with Louisa Degenhardt on the impact of the heroin shortage through the period of the early 2000s, and later got funding for work on the future of tobacco control and the possible contribution of genetics to that with Coral Gardner, and then the Australia Fellowship. And when that finished in 2013, I had might be described as a full-time relapse to drug research as director of what was then the Centre for Youth Substance Use Research, now the National Centre for Youth Substance Use Research. And I've also developed, as we'll see, an interest in the area of wastewater epidemiology. Just a quick flavour of what I got up to in the ethics area. I did quite a bit of work around embryonic stem cells and human cloning, which was very, very hot for a while, almost largely forgotten now. It was a topic that's come and gone. A lot of genome hype, incredibly optimistic predictions about what the human genome would deliver for predictive genomics of common diseases and precision medicine. I also had some interesting time teaming up with lawyers to look at intellectual property law and gene patents, and did some fun work with Jane Lukey and Brad Partridge on ethical issues in the possibility of extending human life expectancy beyond 120 years. I then moved back to the School of Population Health and Public Health Policy, where I began to do a lot more work on tobacco control, continued the work on human life extension, and continued to do work with Louisa Degenhardt, who at this time was doing a lot of work for the global burden of disease on the contribution of illicit drugs. But I also had good fun in doing work on a variety of other topics, including population policy in Vietnam and drug utilisation and the Australian healthcare system, and upskilling in the area of health economics and economic appraisal. And then it was back to addiction neuroethics, which was a nice marriage of my interest in ethics and policy and my expertise in the field of addiction, and did quite a bit of work there with a large team on these issues, which culminated in a paper in Lancet Psychiatry, which was a dissection and deconstruction of the brain disease model of NIDA, which elicited a response from Nora Volko and George Koo. And the wastewater analysis I've mentioned is something that I've become more involved in. Initially, we were looking at illicit drugs. I got interested in the ethical issues raised, but we've since used this approach not only to look at illicit drugs, but to look at alcohol, tobacco, analgesics, pharmaceuticals, and now human biomarkers of human disease state. And of course, as you'd be aware, monitoring community prevalence of bacterial and viral infections, including COVID-19. I'm currently helping with the group at QASE, the Queensland Alliance for Environmental Health Sciences, to use their data they've been collecting to evaluate the effects of policy changes, such as the scheduling of codeine, the effects of the minimum unit price for alcohol in the Northern Territory, and we're currently looking at the impact of COVID lockdowns on the prevalence of alcohol, tobacco, illicit drugs and pharmaceutical use. Okay, enough of a quick overview of what I've been up to. What are some of the things I've learned along the way? Well, I think it's essential, and I think probably even more so today with COVID and all the enormous disruption that's produced to the university sector. One has to be opportunistic. You've got to pick the best opportunities on offer and not be too fussy about trying to pursue your own personal interests. And that often means being open to commissions, particularly those to answer questions that everybody thinks the answers to are obvious, because you're often surprised to discover that the conventional wisdom about various issues is not very well based. Exploring new research methods, and I think that's what I've always been prepared to do, is look to innovations in adjacent fields that might help answer new and interesting questions, and be ready to question what everybody knows or believes, but then critically to find interesting and smart people to collaborate with. That's the critical thing. And be prepared to learn by doing, teaching and reviewing. Clearly not pretending to know more than you do. It's a common error that people don't admit to ignorance. It's much better to be honest and upfront. You don't know something and be prepared to find out about it, and be ready to ask for help from people who know more about something than you do. And clearly under promising and over delivering. I found in the time that I've done teaching, and I think more researchers will have to find the time to do teaching because full-time research posts might become a lot scarcer, is to use your teaching to educate yourself. I use teaching and undergraduate medical students to find out about health economics, medical sociology, ethics, and a variety of other things. There's no better way to find out than have to get up in front of the class and teach. It can be tough and scary at times, but it's a really good way of learning. The other point, I guess the big picture one, is that good research is a social process. It involves a collaborative, competitive process of testing competing ideas, using a variety of methods. Usually these days as part of a collaborative team. The days of the solo researcher in their garret probably long dead. And it often means competing with other teams who are doing similar sorts of research. And that can often be a friendly rivalry, which is I think, good for the field and good for research quality. So obvious tips are to look for a good research group to work with, look for good mentors and peers who are like collaborating. And when you get a bit further on, be prepared to mentor younger colleagues in your turn. A book I often recommend is Robert Axelrod's Cooperation, book on cooperation. And the simplicity and the effectiveness of tit for tat as a strategy of life is nicely illustrated in that book. I think it's critical to be civil to your critics and competitors. There's all too often, people can get caught up in personal animus and attacks on critics, and that's not very effective or useful. And I make a point of reading the papers of people I disagree with, because I find I learn a lot more from that than from reading the papers of people I agree with. I find that ideas are much more likely to be challenged in those sorts of papers. And that strengthens your case and your understanding. I think the other thing I find from the drug and alcohol research is multidisciplinary research is fun. And the drug and alcohol field is an ideal place to do that. I've been able to range across all sorts of fields, the epidemiology of drug use and harms, social context and determinants of drug use and harm, drug policy and economics of drug markets, criminology, history and sociology of drug use patterns and responses, and ethical issues, which are ubiquitous in our field. And that's enabled me to enjoy working with an incredible variety of people from disciplines other than my own. And those collaborations have been enormously rewarding. And they're rewarding if you're prepared to look for people who know more than you do, particularly people who are prepared to share their knowledge and learn from you as much as you learn from them. And that requires an attitude of suspending disciplinary arrogance. I think there's a tendency in people who've trained in one discipline to assume that their own discipline of origin has a monopoly on intellectual rigor and standards. I know that was certainly the case from psychology that I trained in, and you see that to a degree in other disciplines as well. And it also means that you're being prepared to learn enough about the disciplines of people you collaborate with to understand both their strengths and their limitations. And that requires a bit of learning and a bit of study, and more often than not, time spent talking to people, finding out more about what they do. Is it better to be a hedgehog or a fox? As people may or may not know, Isaac Berlin's famous essay on Tolstoy's approach to history introduces the distinction between approaches to intellectual issues, the hedgehog who knows one big thing versus foxes who know many little things. These are very different strategies that people pursue. When one is sort of super specialization, you try to know everything you can about a progressively smaller part of the world. Foxes attempt to know lots of things in fairly superficial detail, and clearly there are risks in both strategies. If you pick the wrong method or field, you can find yourself out of a job. If you're a fox, beware of the risk of being too superficial and too much of a dilettante, a jack of all trades, as the saying goes, and a master or mistress of none. I tried to sort of get the best of both worlds by applying a small set of cognitive tools that I picked up along the way to a diverse set of interesting interrelated topics in the addiction area. And these came from my undergraduate training in philosophy of science and philosophy, postgraduate training in statistical reasoning and the logic of causal inference, in psychology and as much in public health, and a long-standing interest in history and historical imagination, and later on economic evaluation. Trying to influence policy, people often diverge in whether they do or don't want to attempt to do that. If you do want to influence policy, you've got to be realistic about what you like the impact will be. Max Weber famously said in his essay on politics as a vocation that politics is the slow boring of hard boards, that you often work hard and make very little progress. But you do have to be ready when opportunities for change open up, when an issue that you're concerned about, that you're well informed about, suddenly gets to the top of the political agenda and there's policy interest and preparedness to fund something. You need to be ready with suggestions and policy papers. I think in getting involved in policy, it's critical to be truthful. I think that's something that should not be surrendered. It doesn't always make friends, particularly when you do research that produces findings that are a little bit awkward for even the case that you might happen to be supporting. And I think allowing yourself to suppress findings that are inconvenient is the beginning of a slippery slope. And it really means the end of a research career and the beginning of a career in politics. And politics is an admirable profession, but it's very different from being a researcher. As I've said earlier, I think it means being able to write accessibly for multiple audiences. Policymakers and the public rarely read peer-reviewed papers. They do read op-eds and opinion pieces, and they especially like personal briefings because they're very, very busy. And they don't have time to absorb a lot of detail. And you've got to come at an appreciation of the predicament that policymakers face. There's an intense competition for their attention from multiple issues and interest groups. Researchers, from their point of view, are just another interest group in search of increased funding and an attempt to influence policy. So don't be surprised if they're a bit skeptical about your intentions and what you're up to. And from the point of view of politics, public opinion is more important than research evidence when making public policy, and you've got to acknowledge and recognise that the best supported policies aren't always the ones that the public support. And you can do your best to advocate for them, but at the end of the day, politicians in a liberal democracy have to accede to or respond to public opinion. So I'll finish up with some suggestions around publication. And these are probably more applicable than some of the other lessons, I guess, as I indicated earlier, that might have special application for a particular historical period when drug and alcohol research was really in its infancy. But these sorts of lessons, I guess, are universal and ubiquitous, that publication is essential. It's both a moral imperative because research isn't done until it's in the public domain, so people can appraise it, criticise it, learn from it. So it's essential for the collaborative competitive testing of scientific ideas and policy proposals and the dialectic of criticism and debate. So unpublished research doesn't contribute to that. It's obviously a necessity for a research career if you want to get grants, secure academic positions, and get promotions. One thing I'd make a case for is research synthesis. It's an underrated skill, I think, in academia. Griffith Edwards made the point a long time ago that reviews are much more influential than individual research studies. Putting together the evidence in an accessible way that makes sense, that has application to policy, is something that is much more influential. Sadly, it's not reflected in most research assessment exercises, which give priorities to single-authored journal publications in high-impact peer-reviewed journals. And that's had the consequence of what I might describe as a fetish for novelty in research findings, with the consequence of a major replication crisis for research in lots of leading areas. So it's often the most high-impact journals that are the quickest to publish research that fails to replicate, which then wastes lots of people's time. Some rules of thumb. These are based on personal experience and lessons gleaned from people who've written about writing, particularly good writers and editors, because I've had the benefit of some really good editors in my time when I've written for popular journals and others. And I'll come back to these. George Orwell's essay, which is a reasonably short one, Politics in the English Language, is well worth reading for sort of puncturing some of the woollier language that we social scientists sometimes fall into. A very old book by Ernest Gowers, written for British civil servants on how to write plainly and clearly, is still well worth reading. B.F. Skinner wrote an article, underappreciated article, that I'll be cribbing from in the remainder of the talk, How to Discover What You Have to Say, published in an obscure student journal. And it contains lots of useful advice on how to write. And C. Wright Mill's book on sociological imagination has an appendix called On Intellectual Craftsmanship, which is always well worth reading, written for sociologists, but broader application for social sciences. Bit of advice from Skinner. As a good behaviourist, create an environment that's conducive to writing. It's a fairly obvious thing, but people often fail to follow it. That means creating the space and the time to do writing, and it means trying to make writing part of your weekly routine. You can't rely on inspiration or getting a full day to work on a paper, because your time typically tends to be eaten up. Habit becomes more influential for something you do reliably at a particular time of day of the week, and preferably more often than not. And that means preserving time, quarantining time for meetings, against meetings, the time that you're at your sharpest and best. And for me, it was always morning. So I'd ensure that I had at least a couple of hours free in the morning to do some writing before the phone started ringing and people started knocking on my door. But not everyone does that. Some people like evenings. But whatever you do, write regularly so it becomes routine. And as a good behaviourist, Skinner emphasised practice, practice, practice. The more you do it, the easier it gets. Samuel Johnson gave pretty much the same advice back in the 18th century. These are sort of points that Skinner made and ones I've supplemented from advice from elsewhere under the heading of discovering what you have to say. It's sort of like dragging your thoughts out of your head, treating yourself as a resource to discover what it is that you might have to say. And the best piece of advice is it's never too soon to start writing. Einstein said that his pencil was smarter than he was. It's when you got a piece of paper and a pen and you're doodling or scribbling away that you realise what you don't know, and that often the ideas, you find that you have ideas you didn't recognise that you have. John McPhee is a science writer, popular science writer, very successful one, has made the point that it's only by trying to writing that you find out what you don't know. C. Wright Mills suggested carrying a pocket notebook to catch interesting ideas on the fly, just making notes that you can elaborate on at a later date. He also suggested keeping a weekly notebook. Just one day a week, you sit down for a half an hour, and just reflect on what you've learned in the past week. Note any ideas for papers and future research projects, sketch any arguments that you might want to develop in greater depth, write down any really quotable quotes or further reading that you really should follow up. and identify any interesting connections in other fields that might be adjacent to you, where people are wrestling with very similar problems and adopting quite novel approaches that might be applicable on your own. And as to reiterate the point I made earlier about rationality being a social product, you don't work away in your loft on your own and wait to produce a perfectly polished paper that's ready for submission to a journal editor. You really need to talk ideas through with peers and colleagues and be prepared to read other people's drafts and ask them to read yours. Giving talks, even if informal ones, to colleagues, and especially conference papers, are a really good way of pushing your thinking along. The deadline's a potent incentive for writing a paper, and giving a paper to an audience, they'll ask questions that you've taken for granted, things that you just assumed that really need to be justified or developed in more detail. And I always find that writing a paper, I often will prepare a PowerPoint presentation of an outline of the paper, then paste it into a Word document, and then start filling in the dot points in prose. And as I've mentioned earlier, be prepared to use your teaching to develop your own ideas. Work your research into your teaching, because that often the students are really interested about research that you're involved in, that you're interested in and passionate about, and be prepared to offer to give talks on topics that you want to learn about. Think about who you're writing for. We all have to write for our peers in their field to publish in peer-reviewed journals if we want to get promoted. But we should also think about writing for broader audiences, both broader academic fields, adjacent fields, for clinicians who might not be in the addiction field, but whose work involves a fair amount of contact with people with addiction problems. So it might be general medical journals, psychiatric journals. Try to get papers and things into op-ed outlets, write policy papers, briefings, and reports for politicians. And be prepared, as I was, and I find it very rewarding to write for that mythical creature, the intelligent, educated general reader, because that's quite a good test of getting your ideas across to an audience who might not have any pre-existing interest in what it is you're talking about. And being able to grab their interest and inform them is an interesting challenge. The tricks to get it down on paper. Peter Medawar, Nobel laureate in immunology, wrote a paper arguing that the classical scientific paper is a fraud because it misrepresents the rather haphazard process that typically produces a scientific paper. You don't sit down and write an introduction, which leads to hypotheses, which leads to a method, results, and discussion. You typically start with a fairly roughly formulated idea. You start to develop methods. You do some research, you get results, and it's easiest to start often with that part of the paper and to leave the introduction and discussion till last. And you've got to expect multiple iterations before you end up with a publishable paper, and you need to make notes periodically on what remains to be done. You get stuck, postpone the hard decisions until later, make do, sneak up on them, and have lots of busy work for when the ideas won't come. That's the sort of stuff that doesn't require your mind being too heavily engaged in the task. And I found it useful to work on several papers at the same time on different topics. Not everybody does. And when I got bored with one or was stuck on one, I'd move on to the other and alternate. Revision's essential. Again, John McPhee, that the idea that the writer sits down and writes a perfect paper from scratch is express mail from fairyland. You've got to be able to treat your own writing like you would that of somebody else. Be able to summarize your own arguments, appraise it to see if it is clearly set out, it could be better organized, whether there are any weaknesses, if there's anything missing. And if you do get stuck, as I said, put it aside, get someone else to read it and tell you what might be wrong with it. Or sometimes just talking through the paper with a peer is helpful in sorting out what is wrong. It's critical to cut papers. I think they're always better for being shorter, but it's easier to write longer than shorter papers because we typically tend to be verbose if given the chance. And I typically have a rule that the paper, I'm reasonably happy with the argument in the paper, then I try to cut it. It's typically a shorter, more concise paper is better. And simplify the language. We have a terrible tendency to go in for the impersonal passive voice and to write long sentences with the verbs at the end, so the sentence has to be reread several times before the reader knows what it is you're trying to say. And minimize the use of acronyms. I find it irritating to have to go back to the beginning of the paper to work out what it is the acronym. Because I missed the first time it was used and the acronym was used. And I've mentioned the Gower's Plain Words in Orwell's Politics in English Language. The book I recently found is Michael Billig's How to Learn to Write Badly, How to Succeed in the Social Sciences, which is a nice little book on some of the sort of worst excesses of more sociological but social psychological writing. And I think the other final observation is staying sane. Keep it in perspective. PhDs and research papers rarely win Nobel Prizes. Learn to manage your time, basic time management skills, first things first. You do the most important things first thing of the day rather than put them off till later. Critical to learn to say no so you don't take on too much. Not that I've always been successful in that role. Learn to break down the big tasks into smaller bits and avoid the forms of time wasting. But critically, have a life. Have at least one guilt-free, non-working day a week where you don't think about it and you don't feel guilty that you're not working on that paper. And I always find it easier to come back to work if you've had that sort of break. Once you have children, that's really enforced on you because you don't really have a choice unless you're putting your marriage and your children's mental health at work at risk by spending all your weekends and evenings writing books. And it's critical, I think, to have good holidays each year, at least 2 weeks at minimum. Longer is better. So I've taken a bit longer than I thought, but I've finished there. So maybe time for questions.
Yeah, I'll. Thanks very much, Wayne. Fascinating presentation. So the first question I have for you is, when you were 10 years post PhD and you were still looking around to figure out what you would be doing, how did you keep going?
Well, there was certainly a time when I considered giving it all away, which was around about that time. In fact, it was shortly before I joined NDRI. I was teaching 200 medical students who were basically conscripts whose attitude towards the course content was, what's this got to do with medicine? And of course, the ones I had most to do with complained loudly and long about the irrelevance of the course that I was teaching. And I thought there has to be something else. So I went off and consulted a career counsellor, which was a really useful exercise, which really helped me decide that research is what I wanted to do. So I needed to get out of teaching on a large scale, and I needed to find a research position. And then the NDRI position came along, and I decided to take a chance on it in the face of strong advice to the contrary from mentors, as I mentioned. And I didn't regret that choice. So, as I was, as I said earlier, I think I was interested to discover on reading the careers of lots of people who came into the drug and alcohol field, including, as I remember, Robin Room, who basically took a vocation job to work on a survey of alcohol use and ended up being captured by the drug and alcohol field. And I think it's been there are a lot worse fields to work in, particularly if you're interested in doing lots of multidisciplinary work. It's a challenging field for all the reasons we know. The clientele of people with addictive disorders are heavily stigmatized, and the field suffers a bit from that as a consequence. But I think it's been a rewarding field.
So my next question for you is, for a very reasonable person who likes to approach things in a rational manner, you managed to pick up a lot of very controversial topics and have views on them. How do you manage that?
I think that's what I've always enjoyed about it. I mean, that was what attracted me to philosophy. when I was doing my PhD, I probably spent more time in the company of philosophers than I did psychologists. And the fun thing about philosophers, we were always arguing. And it was usually good-natured. I mean, we didn't get too personally involved in it. I guess there were skills picked up from that. You try to be as reasonable as you can. You try to understand the point of view of people who disagree with you. You try to treat their views with respect and dignity, but you defend your view and you put the best case for it. And you just have to be prepared to wear the sort of arrows and blows that occasionally come your way.
So the question then is, are we in this current Trumpian world we're living in, post-information or disinformation age, have we arrived at the point where such civilized discourse is becoming more difficult to engineer?
I think we have. I mean, I've noticed that one of the areas I haven't talked about that I've been involved in largely with Coral Gartner and Colin Morford and colleagues has been the debate around Australia's e-cigarette policy. And one of the most sad things I found about that particular debate is the public health field becoming infected with the sort of Trumpian tribalism around approaches to evidence, where people on either side of the debate about the current prohibition on e-cigarettes or its relaxation are inclined to sling personal insults at each other. So, you know, being in the pocket of the tobacco industry, I've just recently given evidence to a Senate inquiry, and one of the first questions was, you know, this aggressive question as to, you know, swear on a Bible that you've never taken money from the tobacco industry, on the assumption that if you are critical of the current ban on the sale of e-cigarettes, then you're obviously in the pocket of the tobacco industry. And the attempt to discredit evidence that's inconvenient by arguing that it's funded by the tobacco industry. So I think we've seen that sort of infect fields which have been much more evidence-based in the past. One hopes that Biden, the advent of Biden, and I just noticed recently Charles Koch, who's the big money bags billionaire who's funded the Tea Party and the Republicans, admitting that he made a mistake in encouraging the partisanship that's infected American political life, and is now wanting to fund work that encourages people to get together, to find common ground, to work for compromises and encourage deliberation and reasonable debate. So I think the excesses of the postmodernist president, you know, the disregard for truth and alternative realities and so on, has probably turned off enough people. I mean, he still has a base. There are still conspiracy theorists out there, but one hopes that over time, more reasonable people will come forward and more reasonable public discourse will reassert itself and provide opportunities for this sort of sensible discussion that's necessary to arrive at good policy.
So if there's anybody else who wants to really say anything or ask Wayne a question, we have a few minutes left. If any takers? Well, look, Wayne, I'd love to thank you. I think you've got a little book there to be written as a guide for alcohol and drug researchers, or a paper definitely as a guide for alcohol and drug researchers, or for just a guide in life. And it's been a really valuable contribution, very thought-provoking and reflective as ever. So thank you very much.
You're welcome.
And thank everybody. And just to remind you, there's another webinar next week tomorrow. Tomorrow there's a webinar on the impact of COVID. And I'd encourage people, there's a range of presenters talking about the impact of COVID. So if you could check in, or else encourage other people to check in. Thanks very much. And thanks to Liz Baxter for organizing everything. And thank you everybody for your attention. What has been so striking is people have stayed the course for quite a long session. So thanks. And again, before I finish, congratulations to all the awardees for their great achievements. Thank you very much.